Bleeding in early pregnancy is one of the most common reasons a patient will show up in the emergency department. And let me tell you, it's incredibly stressful for everyone involved. Why? Well, because the causes can range from something totally benign to something truly life-threatening. In this explainer, we're going to build a solid, systematic approach to figure out exactly what's going on safely and efficiently.
Okay, so picture this. A patient walks in, she's 9 weeks pregnant, and she's bleeding. Right away, your mind is racing through all the possibilities, right? Is this a threatened miscarriage? Could it be an ectopic pregnancy? But before you can even think about a diagnosis, you've got to have a plan. So the most important question is, what is your very first step?
All right, so here's our game plan. We're going to start with the patient's story, then get hands-on with the clinical exam, look at the key labs, and decode the ultrasound. After we have all that info, we'll put it together to form a diagnosis, and this is the most important part, we'll learn to spot those critical dangerous signs you absolutely cannot afford to miss. Let's jump into step 1. First things first, and this is so important, you have to listen. Before you even think about doing any tests or exams, the patient's story is going to give you your biggest clues. Your job right now is to be a detective and ask all the right questions.
So what are those key questions? First, the bleeding. You need details. How much? Is it bright red, which tells you it's active bleeding, or is it dark brown, older blood? Next up, pain. Is it just mild cramping, or is it a severe colicky kind of pain? That severe pain can point towards an inevitable or incomplete miscarriage. And this is a huge one. Has she passed any tissue? That's a massive clue for an incomplete or even a complete abortion. Then there are the subtler things. What about her pregnancy symptoms? If she tells you her nausea and breast tenderness just vanished, that could be a quiet sign of a missed miscarriage. And finally, always ask about fever, a major red flag for infection.
All right, once you've got the story, it's time to get hands-on with the physical exam. This is where you're going to gather your own objective data to see how it matches up with what the patient just told you.
And listen, this sequence here is absolutely critical. Your first step, always, is to check the vital signs. A fast pulse with low blood pressure could mean she's going into shock, and that is a medical emergency. You have to deal with that before you do anything else. Once you know the patient is stable, then you can move on to the abdominal and pelvic exams.
So the pelvic exam really comes down to two things, what you can see and what you can feel. With the speculum, you're looking. You're trying to pinpoint where the bleeding is coming from. And crucially, are there any products of conception, any tissue visible in the cervical opening? Then you move on to the bimanual exam. This is what you feel. Is the cervix open or closed? An open cervix is a really key sign that the pregnancy is likely not viable. You're also feeling for uterine tenderness, which could mean infection, and adnexal tenderness, that's pain out by the ovaries and fallopian tubes, which is a huge warning sign for an ectopic pregnancy. Okay, history and physical are done. Now we bring in our next set of clues, the lab work. This is going to give us a window into what's happening on a hormonal level. And the star of the show here, without a doubt, is Beta-hCG. This is the pregnancy hormone, right? It's made by the placenta. But it's not just about getting a positive or negative result. The trend of the hCG level over time is an incredibly powerful tool for figuring out what's going on. And here's the golden rule you have to know, the doubling rule. In a healthy, normal pregnancy that's in the uterus where it belongs, we expect that beta-hCG level to just about double every 48 hours. If it's not doing that, it's a major sign that something is wrong. So let's break this down, because this chart is super useful. If the level is rising normally, doubling every 48 hours, that's a great sign for a viable pregnancy. But what if it's rising slowly, or just plateaus? Well, that's a classic sign of either a failing pregnancy or, and this is the scary one, an ectopic pregnancy. If the levels are actively falling, that pretty much tells you a miscarriage is in progress. And if you see really high levels, that should make you think of something different altogether, a molar pregnancy. Okay, labs give us the hormonal story, but the ultrasound, that's our gold standard. It's like we finally get to look inside with our own eyes and see what's actually happening. It's often the one test that gives us the final definitive diagnosis. All right, let's walk through a few classic ultrasound reports you might see. In this first one, we see a fetal heartbeat. Honestly, that is the single most reassuring sign you can find when there's early pregnancy bleeding. That's subchorionic hematoma. It's just a small collection of blood, and it's very often the source of the bleeding. And this combination of findings, it points straight to a diagnosis of a threatened abortion or a threatened miscarriage. The key things are that we have a viable pregnancy and the cervix is closed, even though there's bleeding. It's really important to remember that a lot of these pregnancies will actually go on to be perfectly healthy.
Now, our next report, unfortunately, is a lot more somber. Here, the ultrasound finds one of two things. Either an empty gestational sac, which means a pregnancy sac developed but an embryo didn't, or it finds a fetal pole that tragically has no heartbeat. This is what confirms a missed abortion, which some people call a silent miscarriage. What it means is that the pregnancy has stopped developing, but the body hasn't actually started the process of passing the tissue yet. Okay, this third report has a classic, must-know ultrasound finding, the snowstorm appearance. It's a very specific, kind of bizarre-looking pattern that you'd see inside the uterus. And that snowstorm pattern? It's what we call pathognomonic. That's a fancy word meaning it's a dead giveaway for one specific thing, a molar pregnancy. This is a rare condition where abnormal tissue grows inside the uterus instead of a normal embryo, and it requires very specific management. All right, we've collected all our clues from the history, the exam, the labs, and the ultrasound. Now it's time for the fun part, putting it all together to nail down a precise diagnosis. So the big question is, how do all these clues help us tell the difference between the different types of miscarriages? Because, a threatened one is very different from an inevitable one or an incomplete one, even though they can sometimes seem similar at first. This table is fantastic because it lays it all out so clearly. Just look at that cervix column. Think of it as the gatekeeper. See how it's closed in a threatened or a missed abortion, but it's open in an inevitable or incomplete one. Now look at bleeding and pain. They're pretty mild in a threatened abortion, but they get heavy and severe once that cervix opens up. And what separates an incomplete from an inevitable? The incomplete abortion involves the partial passage of tissue, and the uterus will actually feel smaller than you'd expect for the dates. Okay, let's get to our final and honestly most important section. Because above everything else, your number one job is to keep your patient safe by spotting the red flags that signal a life-threatening emergency. These right here are the absolute non-negotiable, do not miss danger signs. We're talking heavy bleeding, like soaking more than 2 pads an hour, or just severe, unrelenting pain. If the patient feels dizzy or faints, that could mean major blood loss. Fever, chills, or a foul-smelling discharge points to a serious infection, maybe a septic abortion. And if you see signs of shock, a fast heart rate, and low blood pressure, that patient is in immediate danger. This is a true medical emergency. And that brings us to the final, most critical takeaway I want you to leave with today. While miscarriage is by far the most common cause of bleeding, the most dangerous cause is an ectopic pregnancy. It has to be at the top of your list in every single case until you have definitively ruled it out, usually with an ultrasound. So remember, always think ectopic first.